So my name is Sharmia Nehard, and I have the privilege of introducing our next speaker. His name is Dr. Ed Smith, and I'm just going to read a little bit about him. So Dr. Smith is the chair of our medical advisory board. Dr. Smith is an expert pediatric neurosurgeon who holds the positions of the Boston Children's Hospital Director of Pediatric Cerebrovascular Neurosurgery. He is the co-director of the Cerebrovascular Surgery and Intervention Center. He is the co-director of the Head, Neck, and Skull-Based Surgery Program. He's the R. Michael Scott Chair in Neurosurgery and a Harvard Medical School professor. He is also the director of the CCM Center of Excellence at Boston Children's Hospital. He is going to talk a little bit, and then I believe he's going to do questions afterwards. So please welcome Dr. Smith.
Well, thank you for the nice introduction. I realize I only have 8 hours to whip through this, so I'll try to go as quick as I can. Connie had asked me to give this talk a little bit about, what defines a center of excellence. And, the goal here is to try to understand a little bit of what the Alliance is trying to do to standardize care and bring care up to a good level for everybody, because I think that's what our patients deserve. So in reality, this is a work in progress, right? I don't think any of us have all the answers yet of what this is supposed to be, and this is why these meetings are so wonderful, because it's an opportunity for all the stakeholders to get together, the patients, the families, the caregivers, and work out together what is important for having the best care possible. So if you think about that, I'm sort of a simple-minded person, I guess, and I like to think of a lot of things in terms of threes, because 3 is probably the biggest number. Other than orthopedic surgeons, we're not really good at remembering stuff. And with a center of excellence, the question comes up, why have them? Why should we even designate them to exist? What defines them? How do you say what a center of excellence is versus something else? And then who is critical for success, right? This is something to really think about. So it's like, the old elementary school writing assignments. You could ask your W's, and I know there's a lot more W's than just these 3, but that's all I can handle. So the first one is, why do we have centers of excellence? And this is probably the easiest question to answer. Frankly, for the mean, lousy insurance people and people in the non-patient side, higher volume places that do a lot of care generally tend to have lower costs. So if you're a mean, awful, terrible, if there's any insurance people in the room, I'm sorry, but there's a money reason to do it. But more importantly, and I think the reason we have them as caregivers and as families and patients, is that when you have a center that does a lot of something, they tend to be good at it. And so better outcomes is the result of having centers. If you funnel patients to one place, and then you get everybody in that place used to seeing this condition and experienced with handling it, and say, hey, I've seen that before. What about this? Does this pattern exist? The result is you get better care. And this is reflected in the current national guidelines for the American Stroke Association, which came out a couple of years ago, that it makes sense to have centers of excellence, particularly for really complicated things like cerebrovascular disease. And this is for kids and adults. So the why, I think, is pretty easy. This is a little video we put together in terms of the what, and this is obviously biased for the home team here. So this was on our website, but I think it really sums up the reasoning. So if I could ask for a little help with the clicking, you'll hear some jerk talk. A big question we get a lot is, how do you pick a center? How do you figure out where to bring my kid? Because it's your child. It's the most important thing in the world. Obviously, there's a bias here to root for the home team, but I think that's backed up because there's some really important things to look for when choosing a place to try to get the care for your child. One of the first things is you want a multidisciplinary center. You don't want to go to a place where they only offer one kind of treatment, because you're probably only going to get offered that kind of treatment. We have the full gamut: medical, surgical, radiation, interventional, and we all work as a team. The advantage of that is no one really has any overriding goal other than the care of your child. And many of us in the team are parents ourselves, and our real goal is to try to do our best to treat your child just like they're one of our own. By having some of the smartest folks in the world all under one group, working together literally every day, we have clinics together every week. The hope is we can formulate the best care plan for your child, bring the world's best experts right to your doorstep, sort of get you one-stop shopping. And I really think that's one of the unique advantages here, especially when you couple it with the fact that we have probably the largest cerebral vascular research institute in the world specifically for children. So not only do we have the best clinical caregivers, but they're really partnered with the leading cutting-edge research so that we get the best, most advanced care possible for your child. So obviously that's made for Boston Children's, and I'm not trying to just put an ad up for the hospital, but I think you could put that into any hospital, whether that's adult, pediatric, West Coast, East Coast, anywhere. The principles are the same. And so that leads to the next question, which is, what defines a center of excellence? And this is where the team here at the Alliance have done such a good job, and they've really spelled it out very clearly. So there are these things, centers of excellence, and they're expected to meet or exceed the consensus guidelines. So the Alliance has their own guidelines specifically for cerebral cavernous malformations that are printed by the Alliance to Cure and the Scientific Advisory Board. So they said, look, if we think these things are important and we've published these guidelines based on evidence for the best care possible, then the first thing that these centers have to do is they darn well better follow those guidelines. So that's the base foundation. I think the next thing to think about is, how do you become one? And this is where we start thinking about the difference between a clinical center, which is where you might go for your clinical care, getting taken care of for your disease. And then the next level up is sort of the center of excellence, and that's what I've been asked to talk about a little bit today, and I'll talk about how those are different. But these are both things that are sort of sanctioned or given the stamp of approval by the Alliance, and the idea is that you can understand how these are different. I want to talk a little bit about this today because you might see this or hear this on the website, but what the heck does it really mean? And so if you think about the application process, I'm trying to press the button here. Come on, button. There we go. It ain't easy, right? So I'm not going to read all these things here, but suffice to say, these are not rubber stamps that are given out by the Alliance. I sit on the board with some of my colleagues here in the Alliance, and these are hard designations to get. And so when you see it at an institution and they have this stamp on there, this means they've gone through this very lengthy process, submitting a lot of data, submitting their records for how many cases they've treated, their outcomes, what sort of research they're doing. So I want to first emphasize, getting this designation is not an easy thing to do. So this leads into the question, what defines a center? And again, I'll go back to the Ed Smith rule of threes. And I think that when you think about medicine, anytime you're in medicine, when you start off, I think hopefully my colleagues will back me up on this, you get the 3 A's, which are you have to be able, it means you got to be able to do the job, you got to take care of people. You have to be available, because you could be the best doctor in the world, but if they can't see you, it doesn't matter. So you have to be able to get in the door. And the third thing is you have to be affable. These are terrible, hard things. All of you know this, to live through these diseases. And if you don't have the compassion and the understanding to try to relate to the people that have these conditions, it doesn't matter how good you are many times. And I think all three are important. Now, clearly, I would argue that while they're equal, there is a superior among equals, and the most important is to be able. You have to know what you're doing. You can be the nicest person in the world and available all the time, but if you don't have the training or the expertise, then that doesn't help. And that's why I put it at the top of the triangle, but all three are important. And so if you think about this, for a clinical center, not the center of excellence, but a clinical center, there are several things you have to have. So you have to have somebody who's in charge, somebody who's going to take responsibility. It can't be diffuse all over the place. You have to have board-certified specialists. So you can't just have somebody who says, well, I've kind of done this before, I've seen a few cases. You have to have a single point of entry. I think this is a really important thing that the team and the Alliance has done so well. It's so hard to say, well, I got to schedule an appointment with a neurologist, and I got to find a surgeon, and I have to find a geneticist, and to get all those things together is tough. And so the point here is, one of the things to be a center is you've got to have one-stop shopping. You got to come in the door and find it. You got to be able to be seen pretty quickly so that if you do travel out to the place, they can try to coordinate your appointments within 2 days, right? You don't want to fly out there and have 6 appointments in 14 days. It's a lot of time and money and effort to travel. And then the last thing is you got to see a minimum of 25 cavernoma patients per year, which for some people might seem like a lot, for other people might not seem like a whole lot, but this is sort of the bare minimum to be named. And this is surprisingly hard for a lot of centers in the U.S. to meet. There are about 6,000 hospitals in the U.S., and very, very few actually meet this designation. And that kicks it up a notch if you say of those that are centers, clinical centers, which ones kind of get bumped up a notch to the center of excellence. And this is another three thing where you really, what makes it different between a clinical center, which treats patients, and a center of excellence, you have to have the clinical care, but you also have to have research. You have to be pushing the sort of field forward. You have to do something that contributes, like you've heard about at this meeting, to help make the treatment of cavernoma patients better. And then you have to have patient education. You can't just sit on this quietly in a vault. You have to have outreach. You have to have things like this where you can get together and disseminate this information and not just speak, but also listen. And I think that these things are the core principles of what differentiate a center of excellence from a clinical center. So just by the numbers, you have to have at least a couple more specialty physicians, so not just a surgeon, not just a neurologist. You have to have an active research program, and that's defined by producing papers, getting grants, doing the work specifically on cavernous malformations. You have to have at least one patient education event annually. I mean, this is that engagement, that being part of a team. And you have to see twice as many, 50 cavernoma patients a year. So, there's a real, I think, distinctive notch up for what differentiates a center of excellence from a clinical center. So here's the real question. It's all numbers and sheets, and that's nice. For people, everyone here in this room, what does it look like? Or what should it look like? And what I was going to do is show you a little bit of what we have at Boston. It's not perfect. There's a lot of other great centers, some of whom do it better, some of whom do it worse, some of whom do it differently. But at least you get some sense of what we at least have tried to envision in Boston, and I'd love to hear feedback after and questions about how we can make it better. So in real life, the first step, what everybody does, the 3 W's, not the 3 W's I talked about before, the why, the where, and the what, but the WWW, that's the internet. That's pretty fancy for you older people out there like me. It's an internet thing. And so when you first go on the Alliance website, you'll look up Boston Children's Hospital, and there's a really nice list of all the people that are there, what they do, who their groups are. So that's your first introduction into a center of excellence. You go on the angioma site, the Alliance site, and you see this little web blurb. So what happens next? We say, okay, well, I live in Boston, I want to see somebody there. So then you hit the next www, and this is our website. And I want to point out a few things as someone who reviews this with Dr. Fleming and some other folks here in the group. We look for, when you get to the website, a specific CCM link. A lot of places will have, we treat vascular disease or we treat stroke. But the real key thing is, we want people that treat cavernous malformations, and having a specific site for that, I think, is important. I also want to highlight, you want to be able to contact people. I mean, one of the worst things is you get general information, you get a number for the whole hospital, and that doesn't really help you. And you want to be able to just get right in, get right now. And so the other thing is, this should hopefully be something, and this is where we love your feedback, where it's useful when you go there. On our site, we've got this jerk here who talks on these little videos. He's pretty boring. But, the point is, you say, well, what are the common questions that people ask? And when you have an interview with a patient, when you have a patient visit, I mean, many of you know, it can be overwhelming, right? It's hard to remember all that stuff. And so what we've tried to do is to put these videos on here so you say, oh, what was it that he said? You can go back and replay it and see it yourself, or you have family members that maybe are a little more clear-headed in the midst of going through a medical diagnosis, and they can help you with that. And so these are things that are there. We also have a direct connection. Here's our educational outreach where you can go and see what we say, our link to the Alliance so that we're working together with them. I mean, I think showing these connections and having these resources specifically for cavernous malformations is an important thing to see. Now you've seen the website, you aren't scared by that jerk in the pajamas talking on the site, and you say, I want to come in real life. That's what IRL means for you Texter folks. Your kids can explain it to you. And you say, all right, now I'm going to go from the web to a real life. What happens? And this is that, these are the real people. So this is Connor, our vascular administrator, and Megan. And when you click to contact us, These are the real people you get. They only do vascular. They are there for cavernoma patients. They answer the phone, and it's not some random person that changes day to day. They know what the disease entails. They understand what the imaging is like. They get the fact that, this is a really stressful time, and they've been specially trained to sort of hopefully deal well with people and be sympathetic. And I think this is important to have a real person that knows something about the condition and that hopefully provides that first experience when you answer the phone to make it sympathetic and get the job done. So that's the first step of the real life journey. The next thing is when you connect, nowadays it's Zooms and rooms. It used to be you just have to come to Boston or wherever, and now there's this internet thing. And what happens with this? And this is where I think it's really important. If you come to Boston, we actually have our own vascular floor. So for pediatrics, we don't just have a neurosurgery floor, we have our separate building just for cerebral vascular stuff, of which we have our own cavernoma clinic basically on Tuesday mornings just for cavernous malformation patients. And sometimes we change the dates depending on what is appropriate for the families, but the point is this is a key impetus not just for me as one of the doctors in our team, but also for the hospital. They recognize the importance of families and why it's there, and being able to do that in person I think is good. Pre-meeting. What happens if you're, having a meeting? And these are the things we try to recognize from feedback from families. What is it that we should be doing? Well, number one, Connor and Megan, they try to get all the records and all the tests to us before we meet with you. Because it's really hard for us to sort of be flipping through the pictures and trying to say, well, is this picture different than 2 years ago, and how does this look? And so by getting all these things ahead of time, it makes it more efficient and more meaningful when we meet. We try to coordinate our timing, and the idea is that we have multiple specialists all in the room physically at the same time. If it's a Zoom, you see them all on the screen at the same time. So it's not like you have to see the neurologist and then 2 days later you meet with the surgeon and then 2 days later you meet with the geneticist. We try to have everybody there in the same time. We routinely invite the local primary care docs, or if you have a local surgeon or a local neurologist, and they're invited to be on the Zoom with us. The point is, if you have a center of excellence, hopefully you're able to access them, but they may not all be in your backyard. And I think it's really important to say, hey, when my primary care doc, my pediatrician, my internist, they don't know what the heck's going on. And by bringing them into these meetings, even if you're physically in Boston, there's this magic internet thing. They can be on the screen. I've had so many families literally hold up their phone with their family member, their primary care doc, with the FaceTimey thing, I guess that's the technical term, and you can engage with them. And I think that's really important. One thing that for pediatrics in particular is this child life. And so we have a group of social workers and specialists with psychology and psychiatry that can meet with patients and families pre and post visit. One of the hard questions is, well, how do I tell my kid that he or she has this thing, or that they can't play sports, or they can't go to the playground? And that's a hard thing. And it's also hard for the parents. How do they deal with the fact that my kid has this, or my friend or family member? And this is something where we have this child life service where they can meet with you before the meeting. They can understand, and they may say, hey, Dr. Smith, do your exam, but then send Timmy out of the room to go watch video games or something like that while you talk to the parents. You can understand how to make the meeting smoother so there's not that dynamic of stress, or at least less stress, during the meeting. And I think this is really important. Separate from that, and this is not just with kids, but there's all the family stressors of how do you pay for this? How do you deal with this? How do you work with medical leave from your employment? And whether it's an adult or pediatric hospital, making sure you have social work available, financial services available. These are things that are not something the doctor always has foremost in his or her mind, but is certainly something that the family has to come to grips with. And I think this is an important part of these centers. And then lastly, which specialist do you need? Because on the one hand, you want to have everybody you need there, if it's a geneticist, a neurologist, a radiologist, but you don't necessarily want to have 15 people on every meeting. That might be distracting. So part of our job before the meeting is to know, who are the people and the specialists relevant to the visit. So these are all things that go on behind the scenes beforehand in the hopes of making the actual visit as smooth as possible so we can focus on the questions you have and get to addressing the problems that are needed. The other thing is, as I mentioned, this idea of one-stop shopping. And I can't overemphasize, we started doing this about 15 years ago, and it is just such, I think, not only a benefit for the families to save them time and money, but for all the doctors to be in the same room and the caregivers. Number one, the families are hearing the same thing. They're not saying, well, the surgeon told me this, but the radiologist told me this. You're sitting and you can look right across the room and say, all right, you jerks, what's the consensus here? And the other thing is that it allows that real-time questioning where, can I play this sport? Well, maybe the neurologist, the surgeon says, sure, let it rip. I mean, you're not going to hurt anything. But the neurologist will say, oh, they have seizures. They can't drive a car. Oh, I didn't think of that. And that's where having everybody in one place is so important. And I really, in our center, we have big rooms. And because we will have sometimes 6, 7, 8 people in the room at one time, and for those of you that have had Zooms with us, we know sometimes it looks like Hollywood Squares up there. That's an old TV show. TV was something people used to watch. This is the very specialist team. These are some of the brightest minds in the world right here. We had a paintballing retreat. But the point is, we work together. We play together. We know each other. And it really is this sense of building a team. And one of the hopes is with these centers of excellence, they're not just strangers that come together around one patient. They're a team that knows each other, that understands the literature, that knows how to take care of each other. And I really feel this is important. You want to get a sense, when you go to these centers, is there camaraderie there? Do the people know each other? Could you identify them walking down the hall? Have you zinged them in the back with a paintball? Because if you do, you're going to have a better working relationship than if they're a bunch of strangers who just happen to be in the same institution. The next thing here is, I really feel like in the old days, when I started, it used to be that you were the fancy neurosurgeon at Harvard, and you say, you come to me. And now, I really think it's much more important, we're wicked smart now, as we say in Boston. The patient is primary. This is where our focus should be. It should not be the doctors. It should not be the insurance people. It should not be the hospital. It should be the patient. And I really feel that we've tried to physically do that with our waiting rooms. We have tried to do that conceptually. And for an example, what we have is we have our one waiting room, our one exam room with our patient. We have all the doctors come in. You got the neurologist, the neurosurgeon, the social worker, the geneticist. We come to them. We do our clinical visit after all the pre-work, and then when we're done, what we do now, for example, Dr. Kim, who runs one of the research studies here, many of you probably know this, this is our research team, and not Dr. Scott. He is there with the research team. They were not quite that old in our research team here. But then they come in the same room at the end, and they will sign people up for research studies and tell them about it. So the point is, you don't have to leave the hospital and say, oh, should I sign up for this thing? You get everything in one spot. And the hope is that you can combine the clinical goals of taking care of the patient with the research goals of advancing the field, and in that whole window trying to get some education. So this is something I think is really important and I think underlooked, because you can have a sharper scalpel or brighter microscope, but at the end of the day, it's really all about the patient. And I hope that the centers put that front and center in terms of taking care of the people that we're entrusted to see. So the other thing which I've learned over time is some things that seem very obvious to physicians and caregivers. We speak medicalese, right? So my recent graduation, I had to hand this. I thought everybody knows how to say Edward Smith. Well, nope, you got to spell it out, Edward Smith. And I think one of the biggest problems is translating medicalese. We as physicians and caregivers, we do this every day. We can talk about, genetics and other kind of really smart stuff and talk about the thalamo-geniculate nucleus and swanky big words, but that doesn't help. You could be the smartest person in the world as a patient, but if you don't do medicine, these words might not mean a whole lot to you. I don't know half what happens in my car. I don't understand banking. I can barely operate my phone. So, I got more degrees than a thermometer, my kids say, and I can't work pretty much anything outside of neurosurgery. And so I can't tell you how important it is, separate from the medical expertise, to be able to communicate. And this is compounded by the problem that particularly with cavernomas, with cavernous malformations, there are so many specialists involved, And for example, with Dr. Fleming, you got a super smart neurologist. I can't understand half of what she says. And so even between the specialists, there is difficulty with different areas of expertise. And this is why having everybody in the same room and saying, hey, can you explain this to me, please? And it's not always the patient that's asking that. Sometimes it's me. And having that freedom to have that communication is important. Getting hit all at once, too, one of the problems, even though I'm advocating this one-stop shopping idea, it can be overwhelming to sit in that room and you got, oh, the geneticist, oh, the surgeon, oh, the neurologist, and you're just getting bombarded with a ton of information. And this is where I think the after meeting can be important. Making sure you've got the social worker, making sure you've got the resources on the web, making sure you're offering follow-up visits and opportunities to catch up is really important. As caregivers, you have to be aware of this communication challenge. You have to really spell things out. I hate when my residents and fellows, they use big fancy words. Look, you're at Harvard, we get it, you're brain surgeons, shut up. Use regular words, because this is a stressful time in people's lives, and if you're using 10-syllable words, you're a jerk. Get out of my office. Really. If you can't explain something like you would to a 5th grader or an orthopedic surgeon, you shouldn't be able to do the job. In case you don't get it, orthopedic surgeons are lovely people. They're not too bright. They're, they're that step in evolution. Never mind. We'll go on later. And the last thing is, all this so far is about talking, but honestly, I think the great thing about this meeting is the emphasis on listening. A lot of my mentors growing up were sort of old school, Harvard, dusty, average age 180 neurosurgeons, and they talked a lot, but they didn't listen very well. And, being married 28 years, one of the things I think I've learned is you got to listen. And even if you don't want to. And I really feel that the great thing about these meetings is this is an opportunity to listen. And when I'm done talking today, I really hope that you will ask questions, because it is important to listen. It's important to hear people's concerns. It's important to hear that they can feed back the information you just gave them so that you're communicating appropriately. Communication is a two-way street. And if you just give it one way, it may not work. I've driven the wrong way down some one-way streets before. It's not great. So I really think listening is another one of these big, sort of under-recognized important things in centers. Last thing is what happens after, right? You have your visit, you head home, what's next? So at Boston, we have what's called a Tuesday review. So every week, patients from all around the country, all around the world, they send in things to happen, and we have a formal meeting every Tuesday night. We usually, get something to eat or drink. We sit around and we go over the cases of the week. So the point is that we're ready and we're prepared. We have a Thursday conference with a bigger multidisciplinary group throughout the hospital in case there's other stuff like orthopedics or general surgery or things like that. And then we actually have a monthly group. It's not we're having sandwiches, we're not eating BLTs. It's the Boston, London, Toronto group. And the reason that's important is at least Boston Children's, the neurosurgery department, I won't say the bad word, but the U.S. News and World Reports, I don't care for them a whole lot. They rank, neurosurgery #1 at Boston Children's. In London, Great Ormond Street is the big center of excellence in the UK, and Sick Kids Toronto is the #1 center in Canada. And we now have a standing monthly meeting where we review complex cases. And the idea is to say, hey, if I'm not smart enough to know what's going on, maybe at Harvard we don't know what's going on, but maybe at Great Ormond Street they do, or maybe in Toronto they do. And so our hope is that when we see patients in the office, if there's anything that we have questions about, we don't just say, I don't know. We ask for help. One thing I've learned, like asking for directions when I'm driving, I learn to ask now. And I really think this is an important part of centers, and you should ask them. If you have something that's tough, what do you do? And if they just say, well, we show up for review in our group and that's it, I don't know that that's good enough. I think you need to have people that are willing to ask for help, and I know I've asked for help from tons of people here in the Alliance because I certainly know I'm not smart enough to know the answers, and I really feel this is an important part of being part of a center. What happens if you decide to get treatment? Well, pre-treatment, we have a coordinated visit. We do the clinic, imaging, screening. We talk about the social work and child life. How do you prepare for having surgery? How do you prepare for having time off from work? All that kind of stuff. And then if you're interested, research enrollment. Afterwards, we have a team visit. One thing we do at Children's, because this is relevant, is we have a school nurse, and we have our NP team, our nurse practitioner team, directly call the school nurse. And, because it's such an anxious thing for so many families, and rather than act as middlemen, this is something where our nursing team does this routinely for everybody. Can they play in the jungle gym? Can they go outside? Can they play in a sport? This is there. And then we have, as I mentioned, post-treatment Zooms. We usually meet with everybody several weeks after a treatment, whether it's surgery or whatever, and we invite the local teams to be part of it. And I really think that's an important thing to do, and we try to do that together. What happens when you're done with treatment later on? The idea behind, I think, cavernous malformations, it's a lifelong condition. Whether you have a single lesion that's treated and that's it, whether you have the familial form of some sort or another, the point is you live with that diagnosis forever. And I would think a good center has that relationship with your patients so that you're there for them. So we try to maintain long-term connections with families. We get scans every year. We have our annual education events, as I showed on our website and like we're trying to do here. We have our research studies with all our different groups. These are our research coordinators that I mentioned. We have a whole core that just does vascular research, and these very, very bright, young, they're really kids. I mean, they're as old as my kids. They're all going to med school or young residents, and they present their talks, they give their research like some you heard today. We really try to stay engaged with the families and the patients afterwards, because I think this is important, not just for good clinical care, but to understand what the impact of this diagnosis is over the course of someone's life. And so I think this is a lot more than just sort of you do the surgery, see you later, and that's that. So this is what we try to do down the road. I think, one of the questions go up for teachers, particularly for kids, is graduating to adulthood. So I actually went back to school a couple years ago and just graduated a couple weeks ago from MIT. They made me dress up funny. I had to wear pants and everything. And one of the questions is, especially for pediatric patients, what happens when you graduate to adulthood, right? And so, you take care of a kid when they're 10 or 12, and all of a sudden years pass and they're 20, 25, 30, and, they change, right? You got to dress up like a grown-up. I wore this to my graduation dinner. My wife was not happy, but I looked awesome, I'm just going to say. And so, this type of change is important, especially in kids. You've got a new situation. So one of the things Connie asked me to talk about is, how do you handle this transition? And, you got to start this discussion early. At least at Children's, what we do is we try to target normal transition points, right? So people will normally fixate on something. Maybe when they're 18, they go to college. Maybe they get a job when they're in their late teens, early 20s. Maybe they move. Certainly at age 26, a lot of people transition off their parents' insurance. So these are all natural break points that you can think about and plan about down the road and say, let's think about this. We will follow patients for years and years and years, but thinking about being an adult when you're previously a pediatric patient, you have things like family planning. Not relevant in a 2-year-old, but a lot more relevant in a 32-year-old. Alcohol and drugs, other than the 4-year-olds that are out selling meth. No, that's not right. But these are relevant discussions to have, and there are age-related conditions, right? As you get older, things like hypertension, things like cholesterol, all the things that I have. These are all things that are important and you need to do for adults. So the way we do it is we try to find adult teams and using these natural breaking points in the discussion. When do you think would be good to think about this? And we don't want to just say, on this day you're done with Boston Children's, but rather, how can we baton off in a responsible way someplace, if you let us know where you're moving for school, where you're moving for a job? Is there a geography, mix of where you're going? Can we find a doctor someplace that you like? What's the personality like? There may be people we might recommend the best, physician or neurologist or geneticist in the world and wherever, but if you don't like them, then we got to find somebody else. And then where's insurance cover? Maybe as you get a grown-up in a different insurance, you might not be able to go to the hospital near where you are. So all these things, the earlier you know about them, the quicker you can, the smarter you can do transitioning them. And it's a handoff process. It's not a single event. It's something that works over months and years. And this way, it's a smooth transition. You get the records. You maybe even have a co-visit. We also have at Boston Children's an adult care center at the Brigham, staffed by one of our colleagues. So we have this natural physical connection between the adult world and the pediatric world. So this is something that comes up a lot with us. So I've now transitioned to the end of my talk, thank goodness. And I guess just in conclusion here, what I would say, when you say, what is a center of excellence? What is it we are trying to aspire to do here at the Alliance and more globally in healthcare in general for people with cavernous malformations. I really think that the idea behind a center of excellence is to center on the patient. We try to learn the science and the biology and the clinical care. We try to have all the various stakeholders together in one center to define that, and the ultimate goal is to get the patient taken care of as best they can. So that was my little spiel on, I think, what a center of excellence hopefully aspires to be. I don't know that we have that yet at Boston or anywhere, but I know we're trying as hard as we can. And with that, I would love to take any questions you have and love to hear any feedback you might have. So thank you. Yes.
How do you get, this is probably coming, a question coming from ignorance and a lack of doing my homework, but how do you get past the hurdles and the red tapes of insurance? Because I feel like we all deserve to have the best care that we can find, and that we're all interesting cases, and that we could advance this research and the cure for it, but you try to get the care that you need, and you're shot down. And I was told at a hospital, well, if you come in through the emergency room, we can see you. I don't want to go into the emergency room and lie to them that I'm just there. I need your help, but there's nothing really wrong with me, in this moment. How do you get past that?
So that's a great question. In case you haven't noticed, I have a small bias against insurance companies. That probably wasn't clear in my discussion. There's two ways to answer that. I mean, one is the big global, holy smokes, national debate about healthcare, and I don't really think that that's probably something we can practically tackle, at least not in this group. But more specifically, what I've tried to do with my colleagues in cerebrovascular disease is to say, look, this idea of centers of excellence is the first step towards saying, can we show that this provides better care and lower cost? Because that very first slide I showed you, I think, is seminal to the insurance companies. And particularly for relatively rare conditions like cavernous malformations and other things we treat, aneurysms, moya, AVMs, these other cerebrovascular conditions, our group and other have published papers to show that when you have high volume centers, in addition to getting better care, you get lower cost. And to answer your question, what I have done is we now have a packet where we have a number of our publications to show that at our high volume centers of excellence, we can, if you send your patient to us from your insurance company, we can show that we will give you better outcome and lower cost. And that has removed a lot of the barriers. So one thing I would encourage, and particularly for adults as well, and this is an area of focus, is to have your centers of excellence. The first thing is define who they are. Then the next thing is to work on writing papers where we can show that these matter and that it's not just better care, but it's cheaper. Once we have that data and we can go to the insurance companies and say, look, jerk, you can keep them in network and you can get lower quality care where your patients are mad at you, and P.S., it's going to cost you more, or you can send them to Boston or Stanford or Mayo or wherever, and you can get better care for cheaper. And once I think we can show that in a very clear, peer-reviewed way, we've already started to make some headway on that at Boston for a number of conditions, and I think nationally that is probably the stopgap way of answering your question, short of either hijacking the insurance people, having them all get cavernous malformations themselves, or changing national health care. All right. Should I be the manager of the hands, or should someone be the manager of the hands?
We're only going to be able to do one or two more questions.
Okay, so you've got the microphones, you've got one of the two questions.
Following up on this question, what about people who don't have insurance at all? The low income, the undereducated, what happens to them? The format you've put out sounds wonderful, but what happens to those people?
Yeah, that's a huge problem. So the question was, what about people that don't have insurance, or, maybe have insurance that doesn't pay well enough to go to some of the high places? So the education part is a whole separate, I don't have an answer for how we educate people nationally short of things like this. For the low or lack of insurance people, one of the things we've done is I just published an editorial earlier this year looking at a different condition called moya, and we're now working on this for AVMs and for cavernous malformations to show that when you look at what's called the KID database, which is a national database of all the health care that kids get in the United States, one of the things that we can show is that people that have low income, various metrics of socioeconomic status, when they are treated regionally or not treated, their outcomes are worse and their costs are greater. If they get to a high volume center, and we published this in our editorial, it was actually reviewed in the New York Times as well, is that the care they receive at a high volume center, independent of cost or insurance, is as good or better than other places. So one of the things is simply making these centers aware that they exist nationally, and by hopefully increasing public awareness, the fact that these barriers go away if you can just get them in the door. So it's a two-part question, right? One is, can you get in the door? And that's your question about, access and insurance and showing that the outcomes are better. The second is, for people who don't have it or people who have very limited, it is the awareness that these are the places you need to go to get there. The bigger question of, well, how do you protect the uninsured in general? That is a national debate, and I wish I had an answer for that. But hopefully we have some very practical, actionable items that can work for reducing some of these barriers, for increasing access for state insurance, local insurance, no insurance, and hopefully showing that it benefits the common good. The last thing I'll say to that is, I mentioned earlier in this morning's session, especially for pediatrics, if you can show the lifetime cost of burden of disease, and you can say, look, if you don't treat this person, right, let's say they have to come in for a surgery or a hospital for a cavernoma, and that costs 120 grand, and you say, whoa, that's crazy, we're not going to pay for that, they don't have insurance. But if you said, all right, this person's going to then use the emergency department and come in for free care at an expended cost for the next 15, 20, 30 years of their life, well, that adds up to millions of dollars. And that's where these cost-benefit analyses, number one, we have to write them. That's what I think we as clinicians and hopefully this group can do to show that this is a problem and it makes sense. And then two, you have to bring it to lawmakers. You have to bring it to people and say, look, dummy, if you pay 120 grand now, you're going to save $3 million later. Do the math. And so we've done a little bit of that, and I think that's probably the best answer I can give to what your question is. So need smarter people than me though on that. All right. Do we have time for one more? Or are we done? We're done. All right. Thank you very much.